All right, folks, we're going to get started. Eugenia Tsai, one of our full-time liver fellows, is going to wrap up our Controversies in Hepatology series with the discussion on cholangiocarcinoma. So, thanks, Eugenia.
All right, thank you, Gene. So like Gene said, we're going to conclude our Controversies in Hepatology series with discussion of liver transplantation for cholangiocarcinoma. Learning objectives are as listed. A quick overview, we're going to discuss liver transplant for perihilar cholangiocarcinoma, the different treatment options. PSC and cholangiocarcinoma will be reviewed briefly, and transplant for intrahepatic cholangiocarcinoma will also be reviewed in terms of very early cancer versus locally advanced cancer. So just to review, cholangiocarcinoma is malignant tumor of the biliary system. It comprises 10% of all hepatobiliary malignancies, and it's the second most common primary hepatic tumor after HCC. There are three subtypes based on location, the first being intrahepatic, which is 10% of cholangiocarcinoma. We have perihilar, which is 50% of cholangiocarcinoma, and distal or extrahepatic cholangiocarcinoma. Risk factors for cholangio include a PSC, so 30% of cholangiocarcinoma, so PSC patients up to 30% develop cholangiocarcinoma, and the lifetime risk of developing cholangio is about 10%. Other risk factors include fibrocystic liver disease, parasite infection, cholelithiasis, hepatolithiasis, Lynch syndrome, and biliary papillomatosis, viral hepatitis, toxins, diabetes, obesity, and HIV. In terms of diagnosis and screening, it's difficult to diagnose generally due to abnormal biliary tree, and screening strategies are also difficult, but some include CA19-9, ultrasound, and ERCP with fresh cytology. Just briefly, in terms of tumor classification, because this will come into play later when we discuss transplantation, mainly we'll be discussing T1 to T3. T2 to T3. So T2A is solitary tumor with vascular invasion, T2B is multiple tumors plus or minus vascular invasion, and T3 is either a perforation of visceral peritoneum or involvement of local extrahepatic structures. So in terms of cholangiocarcinoma and surgery, so traditionally and historically, single-agent chemotherapy has not portended a very good prognosis. These patients have a median survival of 5 to 8 months. Surgical resection or radical resection is really the first-line treatment. However, the survival rate for these patients, or the median survival, is 11 to 38 months. The 5-year survival is reported at most 45% for these patients. This is generally due to low resectability rates. So a lot of these patients with cholangio cannot get radical resection because 70% of tumors are diagnosed at an advanced stage. Additionally, due to the extent and location of the tumor, they may not be resection candidates. And lastly, underlying liver disease may preclude them from undergoing surgical resection. There's a high mortality from tumor recurrence, which ranges between 53 to 79%. And so in this context, it is thought perhaps transplantation can be a possible alternative treatment for these patients who cannot undergo resection. Just to keep in mind, a 5-year survival rate after transplant of approximately 50% is generally considered an acceptable and good survival rate. So first we'll go over perihilar cholangiocarcinoma. So the early data, this is in the 1990s, in terms of evaluating resection versus transplant. The data is pretty dismal. In comparing hepatic resection with transplant, the 1-year post-survival was 74% in the resection category and 60% in patients who underwent liver transplant. By 5 years, very few patients were able to survive, 25% in the liver transplant group and 9% in the hepatic resection group. In terms of transplant alone for perihilar cholangiocarcinoma, this data kind of reviews up to the year 2000. They looked at the Cincinnati Transplant Registry, and they found that 207 patients were transplanted for cholangiocarcinoma. The 1-year survival in this retrospective series was 72%, with a 5-year survival down to 23%. The tumor recurrence in this population was 51%, and 84% of the tumors recurred within the first 2 years of transplant. Around the same time, our European colleagues also evaluated basically transplant for cholangiocarcinoma. They used their European Liver Transplant Registry, and they found that the 1-year survival was 58% and 5-year survival of 29%, with a 10-year survival down to 21%.
Can you
Yeah.
comment about where the tumor recurrence usually happens?
So tumor recurrence generally is more local, like within the liver. However, there are also more distant metastases that can occur, and those generally, and we'll see that later, are more fatal for the patient. Where if they extend into the duodenum, they can develop fatal hemorrhage. So the early experience before 2005 for transplant and perihilar cholangiocarcinoma is generally pretty disappointing. This was the most robust data that retrospectively was evaluated. So in this study, they found 280 patients with cholangiocarcinoma who were transplanted between the years of 1987 and 2005. They found that the 1-year survival was 74%, 5-year survival, again, poor, 38%, and 10-year survival of 7.5%. However, this study did give us a lot of insight into transplantation. They found that death from recurrent disease was the most common reason for death, with 19 being locally recurrent and 36 due to metastatic disease. They also found certain variables that were associated with improved survival. So patients who were transplanted after 1993 overall did better. Their 5-year overall survival was 45% versus the 30% in patients who were transplanted prior to 1993. They also found that the diagnosis of cholangio prior to transplantation was associated with improved survival, with a 5-year overall survival rate of 68% versus 20% in the patients who their cholangiocarcinoma was incidentally found on explant. This was thought to be due to additional staging. However, in this retrospective study, they were not able to determine whether or not these patients underwent pre-transplant cancer treatment, and if they did, what the modality was.
Do you think also they just only transplanted those that they had small?
Yeah, so that kind of, yeah. So this study also evaluated the prognostic impact of cholangio in PSC, which even to this day is still a little controversial. Generally, this is because cholangiocarcinoma is difficult to diagnose in this subset of patients, and most often it's incidentally found during transplant. So in patients with PSC who have incidental cholangiocarcinoma diagnosis on explant, their outcome was poor. They were found to have tumor staging of 1 or 2. The 3-year survival was around 30%, with a median time to recurrence about 26 months and a median time to death of 30 months. So transplant alone for cholangiocarcinoma really was not a great modality to treat these patients. The next thought is, in these patients who underwent transplant and we find them to have bad cholangiocarcinoma, would adjuvant therapy be useful in these patients? Cholangiocarcinoma is a radiosensitive tumor, and unfortunately, the location often prevents widespread application because of risk of hepatotoxicity. So in 1993, Goldstein evaluated whether or not adjuvant therapy would be beneficial in these patients. It's a retrospective study. He reviewed 701 patients who underwent transplant. 17 of these patients underwent transplant for cholangiocarcinoma. These 17 patients did receive adjuvant radiotherapy and chemotherapy at 8 weeks after transplantation. Patients who received radiotherapy had positive lymph nodes, soft tissue invasion, as well as perineural involvement, and they also underwent 5-FU treatment. In this study, the 1-year survival rate was 40%, at 2 years, 33%. Of the 17 patients that got transplanted, 11 of them died. 7 of the 11 died from recurrence of disease. The 3 that remained alive did not have evidence of disease, and this was at 44, 31, and 28 months after transplant. In the study, they found that patients generally were able to tolerate adjuvant chemotherapy as well as radiotherapy without significant morbidity or mortality. However, the overall conclusion is that adjuvant therapy is not helpful in transplantation for cholangiocarcinoma. And there were other smaller single-center studies that followed that, which basically showed that they had even poorer survival rates. What the studies did demonstrate, though, is that there are certain prognostic factors in these patients. So prognostic factors that portend a poorer prognosis include older age, prior cholecystectomy, CA19-9 greater than 100 at the time of transplant, a visible mass on cross-sectional imaging, and prolonged wait times. However, they also did find in retrospective analysis that there were certain successful prognostic factors, including strict patient selection as well as neoadjuvant treatment. So then this brings us to 2002. The group in University of Nebraska, Sudan and his group, evaluated whether or not radiochemotherapy and transplantation would be beneficial in these patients, specifically neoadjuvant therapy. So they evaluated patients between 1987 to 2000. Ultimately, they were able to select for 17 patients with perihilar cholangiocarcinoma. They excluded all patients who had either extrahepatic or metastatic disease. These patients then underwent systemic chemo and intraluminal bile duct irradiation. They had screening every 3 months with CAT scan to ensure that there was no disease progression. And they found that of the 11 patients who underwent transplant, the median age was 45 years, predominantly male. 7 had PSC and or UC, and only 3 of these patients had decompensated cirrhosis. The pre-transplant complications most commonly was cholangitis, next followed by duct perforation from stent, but they did find that most patients were able to tolerate the chemo side effects. All of these patients who, underwent XLAP when a compatible liver was available for staging, and following transplant, they received cyclosporin and steroids. In this study, they found that with neoadjuvant therapy followed by transplant, the survival rate and free of tumor recurrence was 45%. The mean follow-up in these patients was 2.8 to 14.5 years, and explant pathology was T1 to T3, no nodes and no MEPS. In 2 patients, there was tumor recurrence. They were both within first 6 months of transplantation, and ultimately they died from fatal hemorrhage. So after the University of Nebraska, the protocol was adopted, modified, and adjusted by the Mayo Clinic group. And they looked at the prolonged disease-free survival of transplant plus adjuvant chemoradiation. So they adjusted the protocol a little bit and is considered the Mayo Clinic protocol. They use external beam irradiation with a bolus of 5-FU. These patients then underwent transcatheter irradiation. They also underwent XLAP for staging, and patients were kept on 5-FU, underwent liver transplant, and at that time, immunosuppression was prednisone, cyclosporin, and azathioprine. Of note, even after irradiation plus or minus 5-FU, these patients underwent XLAP, and 6 were actually excluded based on the XLAP because they were found to have metastases on surgical exploration that was not found with just imaging modalities. And then ultimately 11 were made it to transplant. So in this prospective study, 11 patients made it to transplant. Mean age was 46, predominantly male. 6 of these patients had PSC, 2 had cirrhosis. The mean time from diagnosis to transplant was less than a year, just 211 days. Mean UNOS waiting time was only 169 days. UNOS status at that time, this was before 2002, so UNOS was status 2 and status 3. Pathology on XPlan ranged between stage 1 and stage 2, and only 1 of these patients had stage 4A disease. The follow-up at the time of this publication, 8 of the patients had greater than 12-month follow-up, and the other patients were still undergoing follow-up after transplantation. 10 of the 11 patients were disease-free and alive, and only 1 of the patients had disease relapse, which was asymptomatic. So this study had a very strict selection criteria. They didn't have any longitudinal size limit. However, they did have a radial criteria where the tumor size could not be greater than 3 centimeters. They didn't allow for any patients to have intrahepatic or extrahepatic metastases. They also excluded patients with positive lymph nodes. So this strict type criteria, ultimately only 60% of patients underwent transplant after the selection. They found that preoperative irradiation and chemotherapy toxicity was generally acceptable in this population, and that negative surgical resection margins was better for survival. The disease-free and overall survival rates for this population were generally favorable. So then after that study, they actually had a follow-up publication where they had a greater size cohort. They had 71 patients in the transplant treatment protocol, after which they ultimately were able to send 38 of them to transplant. In this 38 patient group, the median age was 49, again, predominantly male. 65% had PSC, 25% had a prior PTC, 19% had prior cholecystectomy, and the mean CA19-9 at enrollment and pre-transplant were above 100. 21% of these patients had mass seen on imaging. What they found is actually that at 1 year post-transplant, the survival rate was up to 91% in these patients. And at 5 years post-transplant, they had a success of 76% survival rate, which is significantly improved compared to all the other previous studies.
How did they have no masking when they had unresectable?
How do they have?
Only 20, they all had unresectable perihilar cholangiocarcinoma.
Oh,
So
yeah.
I'm like, how do you,
With like,
but to define them as unresectable, like, how do you define them as unresectable by positive cytology?
oh, it's either unresectable patients or it's patients with PSC. So patients with PSC may not necessarily have a mass on imaging. They may just have like a stricture.
So those are the people who had an incidental one at transplant?
No, these are all prior diagnosis. So like Dr. Sciano mentioned, like if they underwent an ERCP.
And had
And they-
positive cytology with no mass.
Right.
Okay.
Yeah.
So it's obviously a very select group.
Right, a very strict criteria. Yep. So what they found in this study is that there's certain risk factors that were associated with disease recurrence, which is highlighted in pink. So age was associated with disease recurrence, pre-transplant CA19-9 greater than 100, history of prior cholecystectomy, anyone who had residual tumor greater than 2 centimeters, mass on imaging, perineural invasion, which was found at surgery, or tumor grade 2 or 3. Those were higher risk factors. PSC, gender, CA19-9 at the time of enrollment, and prior PTC was not associated with increased disease recurrence.
What's residual tumor and negative? Like protective?
No, not protective. They're all associated with increased risk.
Oh.
Yeah. The pink are increased risk of
Okay,
disease
this is-
recurrence.
Yeah, that has.
Oh.
Yeah, it's protective.
It needs 10,
Oh, I might have written that. Actually,
or is it less than 2?
oh, I must have meant less than 2 centimeters. Yeah. Yeah. Sorry for that. So based on this data, actually, in 2009, UNOS and OPTN approved the MELD exception score for patients with perihilar cholangiocarcinoma who completed a standardized neoadjuvant therapy protocol. But due to the lack of data available, they basically used the MELD score designated for HCC to be given to patients with perihilar cholangio.
Do you know how many of those patients did not have any residual tumor on the explant? Do you remember, like, roughly?
I can't remember, sorry, the number of patients.
You're
Yeah.
asking the
But,
impact of neoadjuvant therapy.
I mean, my recollection with this study is that they included some patients with just looking at the CA19-9 and history, and like not necessarily everybody was like cytology proven. And I mean, maybe we can look back eventually, but one of the other issues with this chemoradiation that they were giving when you look after the explant, because it kind of burns the whole area, you don't really see much. Like, so everything is basically gone. So sometimes you don't see any cancer.
oh, yeah.
So
that
if
makes
you really don't confirm the diagnosis before transplant, you sometimes enroll patients that don't
have,
really
yeah, that's true.
cholangiocarcinoma.
Right.
From what I remember, like some
I
people
think
were-
you're actually right, yeah, that not everybody was confirmed with tissue or with cytology, that if they had suspicion for
because if you
cholangio.
have just a CA19-9 that is like 200-300, and you have like history of PSC
And a
or
dominant
arthritis,
stricture or
that would be,
something.
like, mostly elevated.
Right, that's true.
But I don't think they would put them to chemo radiation unless they had
Yeah,
some
that's where I
biopsy or
don't.
something.
Yeah.
I don't think they would do that.
I mean, we can go back. and
Yeah, I'll have to look back, but I think,
Show it, but to select these
can't
patients as cholangio, I'm sure they have to have some sort of control.
I think cytology or like dominant stricture at the very
I mean,
least,
and the questions have to be cholangio.
right,
I can't imagine them proceeding with all this and they
with
would
it not
stop.
confirmed.
Oh, and by the way, the Mayo Clinic also has like they do also like fish analysis on the side. So they use different criteria.
Different,
like
yeah.
that. Because they use like trisomies and some of their positives, so it's a little bit different.
Yeah, that's true. So after the Mayo Clinic published their protocol, a lot of other institutions started implementing the protocol to try to transplant patients with cholangiocarcinoma. So this is a retrospective study evaluating transplant at 12 large volume transplant centers with a total of 287 patients, although they did note that most of the patients came from one center. Post-transplant recurrence-free survival rates was at 2 years 78%, at 5 years 65%. They found shorter survival times in patients who had a tumor mass greater than 3 centimeters, patients who underwent transperitoneal tumor biopsy, and patients with metastatic disease. So then the question became, was it the strict selection criteria that they implemented, or was it actually the neoadjuvant therapy that they implemented that helped these patients have improved survival rates? So a group in Europe used the European Liver Transplant Registry and retrospectively studied this. They were able to find 28 patients who met the strict selection criteria of the Mayo Clinic protocol who did not undergo neoadjuvant therapy. And what they found is that they had a higher cumulative survival compared to patients who are not meeting the strict selection criteria, and they also had a lower probability of recurrence of tumor. However, the limitations of these studies is really that not all the selection criteria were met. A lot of the tumor biology and tumor size information was not available because it was a retrospective study, and their 5-year survival rate was actually lower than that of the Mayo Clinic series. And it was difficult to determine in the patients who did whether or not they did receive neoadjuvant therapy and adjuvant therapy, what modalities were used. And so based on the study, they couldn't distinguish the contribution of strict selection versus neoadjuvant therapy, so the recommendation is to continue with the Mayo Clinic protocol. So at this point, the protocol has been optimized, and so the first step is to exclude metastatic or nodal disease. Patients generally can undergo biliary drainage to either alleviate symptoms, treat cholangitis, or enable the liver to tolerate neoadjuvant therapy. They undergo neoadjuvant therapy with keeping in mind that possible morbidities include acute cholangitis, cholecystitis are the two most common complications. They can also develop ulcer, delayed gastric emptying, and decompensation. These patients then undergo operative staging. And in this study in the Mayo Clinic series, they found that approximately 20% would be excluded because of positive staging due to lymphatic and peritoneal spread. They then undergo liver transplantation. Anyone with residual viable cancer, this was categorized based on whether or not they had a complete response, marked response, moderate response, or minimal response. And this was actually independently associated with the probability of disease-free response. Anyone with high-risk features, so this is, as the management with immunosuppression for these transplant patients changed over time, their protocol also changed over time. So before they were using cyclosporin and steroids, they've then progressed to tacrolimus, and then at this point, their most updated protocol is that in high-risk feature patients, they would switch to sirolimus and then add adjuvant chemo. And then in these patients, they do recurrent screening at 4 months after transplant, at 12 months after transplant, and then yearly with CT and CA 19-9. So PSC and cholangio, we already talked about the lifetime incidence. In the study, they found that PSC-associated cholangio, generally the age of diagnosis was younger, and the time of transplant was also younger for these patients. PSC patients did have a higher risk for multifocal cholangiocarcinoma and are generally considered better candidates for neoadjuvant therapy and transplant. The current listing criteria for these patients is diagnostic luminal cytology or biopsy, or malignant appearing stricture with one or more of the following, which is high CA 19-9, aneuploidy by FISH, or mass on cross-sectional imaging. In the Mayo Clinic protocol, they had 171 patients with PSC, and the 5-year survival rate for these patients was 77%, which is pretty good.
So you're saying of those who developed cholangiocarcinoma on the backdrop of PSC, it was in the first year of their diagnosis?
Yes. Yes. Most of them.
So it's almost like some people have a cancer predisposition, because that's
That's pretty quick, yeah.
High, quick,
Yeah.
No, but I think it's the jaundice that brings you to the attention of a doctor. That's when your PSC gets
So you think you're diagnosed with the cholangio and the PSC at the same time? Because that's just pretty high. I mean, you think of the number of PSC patients I mean,
Yeah,
you don't see
I think it's
50%
just
of the
that they
first
get
year.
diagnosed with PSC, but
Yeah, it's the presentation, they already have it, yeah.
But I think that, probably on the surgical side, you see patients who are presenting with cholangio as their initial presentation, and then they're ultimately found to have PSC.
Yeah, that's what you say. So that's why it's saying within 1 year of your PSC diagnosis, you actually present.
That's like the other way around.
Yeah.
So you can get patients in here who end up not having cholangiocarcinoma. There's the diagnostic listing criteria is not absolute for having cholangio. They're going to be false.
Yeah.
Yeah. I think that's how they get their survival rate up.
Well, that's,
That's
you're
basically-
saying,
that's
you
exactly
know,
what
that
I
there were
said.
people in that study that didn't actually have cholangio, so.
It hasn't changed.
But you have the top that was 50%, right, on explant.
Yeah, like tumor staging, yeah. Mhm.
50% didn't have.
No.
Okay, so switching gears a little bit, transplant for intrahepatic cholangiocarcinoma. So hepatectomy is curative for primary intrahepatic cholangiocarcinoma. Unfortunately, so this study evaluated 82 patients, and within those 82 patients who underwent hepatectomy, 51 developed recurrence. 65% were intrahepatic, 54% were associated with multiple tumors, and 86% of these patients developed recurrence within the first 2 years of surgery. Survival after resection is dependent upon tumor size, number of nodules, the level of CA19-9, and whether or not there's vascular invasion, the margin status, as well as the presence of nodal disease. So resection is the curative treatment for intrahepatic cholangiocarcinoma. However, the overall and recurrence-free survival rate is low. It's 25%. Traditionally, intrahepatic cholangiocarcinoma was a contraindication for liver transplant due to incidental or misdiagnosis. However, in patients who are poor surgical candidates, what can we do? Can we consider them for transplant? And what the study found is that they're in patients who underwent transplant, they were able to find tumor recurrence-free survival. Patients who had low-risk disease were 78% survival, and patients who had intermediate or high risk had a lower survival rate of 19%. Factors predictive of tumor recurrence, again, were similar: multifocal tumor, perineural invasion, infiltrative growth pattern, lack of neoadjuvant or adjuvant therapy, history of PSC, if they had hilar tumors, and if they had lymphovascular invasion. The early data was very limited. A lot of the studies came out of UCLA, so it was limited. It was a small single-center case series. Over 2 decades, they transplanted 25 patients for locally advanced intrahepatic cholangiocarcinoma. The 5-year overall survival rate after transplant was 32%, which is low, but the data reported is for both intrahepatic cholangiocarcinoma as well as perihilar, so it's difficult to differentiate which one it was for. A small number of these patients did receive neoadjuvant therapy, but it was unclear what kind of therapy since there was no standardized protocol. So this is a retrospective study where they evaluated liver transplantation for very early intrahepatic cholangiocarcinoma. The indication for transplant for these patients was either suspicion for HCC or they had end-stage liver disease without liver nodules. These patients had incidental tumors that were detected on pathology that turned out to be cholangiocarcinoma. Very early was defined as a single tumor less than 2 centimeters, and advanced was a single tumor greater than 2 centimeters, or if they had multiple tumors. So of all the patients who were transplanted, 48 actually had intrahepatic cholangiocarcinoma. So 15 of the 48 had very early tumor, and 33 of the 48 had advanced tumor. What they found is that the survival rate was better for the very early group versus the advanced group, and that the risk of recurrence was higher in the advanced group as opposed to the very early group, which, makes sense. And this is just the numbers in terms of 1-year survival for very early was 93%, at 5 years 65% versus advanced 79% at 1-year survival, and then 45% for 5-year survival. tumor recurrence was high in the advanced stage, 30% at 1 year, 61% at 5 years. So in this study, they were suggesting that in patients who have cirrhosis and very early intrahepatic cholangiocarcinoma, they may be candidates for liver transplantation. However, prospective studies would be needed to further study this. Then,
Did they comment in that study about the cause of death at 5 years? It's because the recurrence rate is quite low, but still 65% survival at 5 years. So great. It's not just tumor recurrence.
right, I don't recall actually. I'll have to look back to it, sorry. So more recently in 2018, the group in Texas, they evaluated transplant for locally advanced intrahepatic cholangiocarcinoma. It's a small case series. They were able to include 21 patients. These patients had biopsy-proven unresectable intrahepatic cholangiocarcinoma, and they described locally advanced as tumors, single tumors greater than 2 centimeters or multifocal tumors. These patients did not have extrahepatic disease, no macrovascular invasion, or lymph node involvement. These patients underwent neoadjuvant therapy followed by transplant, and they had to have stable or responsive disease after 6 months of neoadjuvant therapy before they could undergo transplant. The radiotherapy in this study actually was selectively used by authors, so they kind of underwent different modalities. So 21 patients were referred, 7 were excluded because of extrahepatic disease progression, 2 actually were downstage to the point where they were resectable. So ultimately 6 of these patients went for transplant. 3 of them received extended criteria deceased donors, 2 were domino living donors, and 1 was a standard criteria. So the median duration from diagnosis to transplant was 26 months with a median follow-up from transplant of 36 months. The 1-year survival was 100%, 3 years 83.3%, and at 5 years 83.3% survived. The disease recurrence was in 3 patients, all within the first year, but the recurrence-free survival is 50% at 1, 3, and 5 years. Of note, these patients actually had low MELD, and so the livers that they received were generally discarded by other centers, which is why they were able to get liver transplantation.
What happened to the other 6 people?
Which other 6?
21, 9, 6 is 15, there's 6 more people out there.
Oh, I think, so some of them just decompensated or just had non-related, non-tumor related complications.
Those 6 people wait long to get transplanted and prove that they didn't have cancer coming back before transplant somehow?
These 6 patients or the other 6 patients, sorry?
Well, that's what I'm curious, is that the difference?
Oh, those other 6 patients they died. They didn't make it to the transplantation.
These patients waited a long time. It was 26 months before
Yeah.
they got transplanted. So
They proved that the cancer wasn't coming back before they got transplanted.
Yeah, that they were stable disease. Sorry, what'd you say, Dr. Green?
Oh, wow.
And the follow-up is
those 3 disease recurrence. I think they did.
the median follow-up is 36 months, but therefore 5-year survival rates.
Yeah. But
You don't have enough time. The interval is 29 to 51, which is less than 5 years. So they extrapolated probably from the curve, but I don't know if we're going to get 5-year survival rates.
Well, that's probably the 70th percentile.
Yeah, but still, we have 1 patient, but
yeah, there's 6 patients lost.
Just 1. So then someone thought perhaps we can evaluate liver transplantation in patients who have resectable cholangiocarcinoma and what is the benefit compared to resection. So in this study, which was published just recently in 2018, it was a retrospective study at 10 institutions, and they evaluated patients who were undergoing curative intent resection for cholangiocarcinoma and compared it to patients who underwent transplant for cholangiocarcinoma. The median age in terms of resection, the age was a little higher. There was more PSC in the curative intent transplant group, and in terms of chemoradiation, the patients in the transplant group generally received chemoradiation. The overall survival rate was significantly different between the transplant and resection group. At 3 and 5 years, the transplant group did better. And if you subdivide and look at the non-PSC patients who had tumor less than 3 centimeters, their survival at 3 and 5 years was better for the transplant group. So then the question is there a shifting paradigm that these patients who can get resected, should they go for transplant? That's just like a little food for thought. So conclusion in terms of perihilar cholangiocarcinoma, if you have unresectable disease, if it's localized and there's no lymph node involvement, there is an established strategy with a strict protocol that has demonstrated excellent results in terms of 1 year and 5 year survival rates. In intrahepatic cholangiocarcinoma, if they have unresectable disease, if it's localized and they have lymph node negative disease, in very early patients and even in locally advanced patients, perhaps transplant can be good for a highly selective group of patients. There's promising results out there, although all the studies have been small and there's still a lot to be determined. The limitations of a lot of this is the donor organ shortage. So all of these patients had very low MELD scores, and in areas like ours where patients are transplanted at high MELD scores, it's difficult to get these guys to transplant. Again, a lot of these studies that we reviewed are retrospective studies, so they have imperfect comparisons, and the prospective studies that have been performed are with very small groups of patients, like 6 patients, 11 patients, the largest being the Mayo Clinic group. So what do we do for these patients who may not necessarily make it to transplant with cholangiocarcinoma? Some options would be just resection versus radioembolization, and this is some of the modalities that we use here at Sinai. And then more recently, there's also just attempts at multimodality, so using neoadjuvant systemic chemotherapy and chemoembolization in combination with surgery to try to treat these patients with cholangiocarcinoma who are not necessarily going to make it to transplant. So that's basic. Yeah.
Questions?
So in the Mayo Clinic, the bigger one, 2006 experience, I think they also found a lot of vascular and biliary complications after the transplant. They talked about, what you received before the transplant, but then after, they had a lot of problems, and I think that they felt that was the case because of the
radiation
and the chemo. So that's something to be on the lookout for in these people.
Right.
We have the protocol for cholangiocarcinoma here, sanctioned protocol. And I can't remember that we've had one patient actually go through the whole entire prioritization and get transplanted because they drop out. The patients that we see drop out.
Yeah, they just don't make it.
So do you know at which point they drop out?
Well, we just had one recently, that went for a live donor transplant. And they went in there and they were positive lymph nodes, so that they backed out. So a couple of the ones I remember were at the laparoscopy, and then a couple of them just had progressive disease despite that.
And the protocol we have is for the hilar, perihilar, right? Not for the intrahepatic.
Use the same diagnostic protocol as Mayo, or you're using a different protocol for diagnosis?
In terms of
The histology and cytology and stuff like that.
I'm pretty sure it's very similar, if not the same.
It's not, I talked to the fish is the tricky part. Because the fish that they're doing here is not exactly the same trisomies that they're doing at the Mayo Clinic. And talking to Jawad, he sends a lot of the brushings and stuff for fish. He says he can do the same patient multiple times and get opposite answers. He doesn't really trust the fish results. It's just kind of random what you get back.
Any other questions? Thanks, Eugenia. Great
Thank
job.
you.
Thank you.